Sure.
but we'll have a lot of online students.
Yes.
So, good evening, everyone, and welcome back to the session. And we have with us Dr. Sharath, and this is a new way of learning where the student and teacher. Good to see Prasoon Vaidya today. Prasoon is supposed to join, but we missed her. No worries. Amrit also has joined. Excellent. So, in a slightly different method, instead of only teacher didactically speaking continuously, let's have a perspective from the student. So, Sharath, you are preparing for which exam?
FMG exam, sir.
Great.
FMG.
And when are you taking the FMG?
This like coming August, September, sir. Still we didn't get notification, but preparing for these sessions. Sir.
Great. And what are the challenges as a student preparing for the foreign medical graduate exam? You pass it through in the past 2 years.
Yes, sir.
You think that it was very difficult to catch up on basic sciences, anatomy, physiology, and all that, or what are your very strong subjects?
Like from my side, I have preparing from previously. I started from this probe subject, sir, and basics, the anatomy, physiology, and biochemistry was a bit. Right now, the paper was a bit hardened.
Great.
And from Obs Gynae, PSM, and some surgery topics were good, sir.
Very good. And you took the most recent December FMG exam once?
No, sir. No, sir.
Oh, not it. Okay. Okay.
Not it. Before session, before attempt I took, sir. Last recent attempt I didn't took.
Wow, that's good. So we also have Prasoon joining. So Prasoon, on your laptop, you need to put up the voice. You are able to see the YouTube broadcast on your laptop.
Oh.
Yeah. Got it?
I have to get my laptop, sir.
No. You are having in the background the sound coming from the laptop, I believe.
Okay.
Yeah. Okay. Yeah, now fine. That's great. So today we have Prasoon and Sharath. Excellent. So let's make the great beginning. Let us solve some questions together. And that is how the learning is supposed to be. Yeah. Last time, yes. Very good. Now, you give an answer. If you have any extra points to add, just add up those extra points. That's the plan. So now let us start with Sharath. Krukenberg spindles. Where do you see Sharath? Good to see around 13 online students. The online students can also punch your answers so that let's have it like a group session. Yeah, Sharat, what is your
Yes.
potential answer?
Posterior surface of cornea, sir.
Posterior surface of the cornea. Absolutely right. So basically, the Krukenberg's um, spindles, whenever you have a secondary open angle glaucoma, there will be a dispersion of the pigment granules
Yes.
from the iris pigment epithelium, and they deposit toward the anterior segment. So accordingly, you have what are called Krukenberg spindles, which will be forming along the cornea's posterior surface, is what you need to remember. Very good. Now, Rasul, what is your answer? Aqueous humor is produced by. Prasun, are you there in the stream? Yeah, you are there. 1 minute.
Plicata.
That's good. You are there in the stream. Okay. You like to say,
Pars
yeah,
plicata.
okay. Pars plicata. So what you can do, Prasun, there is some amount of resound coming from your side. That's the reason after you tell the answer, you can, after you finish speaking, you keep muting the mic, okay? Now, so typically aqueous humor is produced by pars plicata, which are along the crest of the ciliary process. So whenever aqueous humor is produced, there are three physiological functions. One is diffusion, ultrafiltration, and active secretion. And typically, aqueous humor is hyperosmotic. Around 1.5 to 4.5 microliters per minute is being produced. 99.9% of the aqueous is water. That's what you need to basically remember. Now, the question once more goes to Prasun. What is the most common cause of the angle closure glaucoma?
So pupillary block.
Pupillary block. Absolutely right.
It will
Yeah.
block the
Okay.
IV
And
uveoscleral flow.
okay. So it is a pupillary block. Now, a question to Sharath. Letanoprost, how does it act in treatment of glaucoma?
Letanoprost is uveoscleral outflow. Increases the uveoscleral flow.
Very good. So it increases the uveoscleral outflow, as we have discussed last time. Now, laser iridotomy, where is it useful, Prasanna?
Sir, in angle closure glaucoma, it was discussed earlier also.
Good. So in the case of the angle closure glaucoma, it is very useful. Once more, where do you see Krukenberg spindles? Sharath.
Posterior surface of cornea. Capsular cataract.
In which condition? In which condition? Out of these four, where do you see? Just before we discussed.
Pigmentary syndrome.
Absolutely. In pigmentary glaucoma.
Pigmentary dispersion syndrome.
Yeah. Now, glaucoma flecken is a feature of which condition, Prasun?
So acute angle closure glaucoma.
Okay. You have any points to add? So you can always prepare 1 to 2 points to add when you are attending the session. That will make it very, very high yielding. Always, as classmates, when we all sit together and prepare, this guy tells 2 points, that girl tells 2 points. That's how the preparation is more dynamic than even attending coaching centers. Be very sure. So glaucoma flecken is a feature of acute angle closure glaucoma. Glaucoma flecken is formed under the anterior lens capsule after an attack of acute angle closure. And mainly it is the necrosis of the lens epithelium which is responsible for the glaucoma flecken. You can see very clearly the glaucoma flecken in the case of acute angle closure glaucoma. So this is an example of a posterior subcapsular glaucoma, which you see in case of the chronic anterior uveitis, high myopia, hereditary fundus dystrophies, etc., etc. Whereas glaucoma flecken, it forms with acute angle closure. That's what you need to appreciate. Now, the next question goes to Shravan. Laser which is used in the after cataract surgery.
And NDI lasers.
Excellent. It is the NDR laser. Typically,
Its wavelength is 1064 nanometers.
Excellent. Any other points you like to add? So, typically it is the NDR laser which is used in the treatment, and this is how the posture capsule following the NDR laser treatment, how it looks like. Right now the question goes to Prasul. Rosette cataract. Where do you see?
So it's seen in blunt trauma, rosette cataract,
Okay.
and there are various other types of cataract also, sunflower cataract. Then
Yeah. So can you tell me where do you find sunflower cataract?
Wilson's disease, sir.
Okay.
Wilson's.
So blunt trauma is the place where you find the rosette cataract.
Yes.
And
Snowflake cataract in diabetes, sir.
excellent. Snowflake cataract in diabetes.
And Christmas tree pattern seen in myotonic dystrophy, sir.
Super. And concussion, you have a rosette-shaped cataract. Radiation injury, you have it's called glass blowers cataract.
Glass blowers.
Whenever there is an infrared radiation.
Yes.
And sunflower cataract you see with chalcosis, copper deposition, and etc. Now, the question goes to Sharad. Second sight is a feature of which condition?
So nuclear cataracts.
Excellent. Any comments? So basically, if you look at the symptoms of cataract, frequent changes of the glasses, because the rapid change in the refractive index of the lens is a common presenting feature. Second sight or myopic shift in case of the nuclear cataract causing, once cataract occurs, there is a change in the refractive index. So that leads to index myopia. Because of the myopia, the near vision improves. That is the reason it is called second sight. Because of the myopia, because the cataract refractive index changes, that induces myopia, and that myopia will improve the near vision. That is the reason it is called second sight, is what you need to remember. Right? Now, Dr. Prasoon, your question comes. A 65
Yes, sir.
there is a gradual painless reduction in vision 1 year after vitrectomy. What is the likely possibility?
Sir, it is due to steroidal use, post subcapsular cataract due to long-term use of steroids.
Very good. So,
And additional point for this was gradual painless loss of vision could be due to progressive pterygium, corneal degeneration, developmental cataract.
right. Very good. Very good. So, Prasun, your cam is not coming. I don't know. Maybe. Uh, okay. Now, what are the most common causes of the blindness in the world? Sharat has seen a larger world, all the way from China. Which university in China you studied, Dr. Sharat?
Zhejiang, sir. Zhejiang. Jiangxi city.
Is it very far from Wuhan or close to Wuhan?
It's around from 3 to 5 hours distance from Wuhan, sir.
Oh, so what are your juniors telling? Is Wuhan nowadays become safer once more or challenging?
Yes, sir. Right now, all are moved to India, sir.
Most of
Previously, most of the people were moved from Wuhan.
okay,
Right now, the situation is okay. The lockdown is everything was done. Nice.
okay. So our Dr. Sharath is from Vishakhapatnam in Andhra Pradesh, and he finished his internship from the King George Hospital, one of the prestigious hospitals of Andhra Medical College. Very good. Now, the most common cause of the blindness, what is it, Sharath, in your opinion?
Like most common in world means like cataract, sir.
Okay.
From India means refractive error in India.
Okay. The most common cause world is cataract. Absolutely. Now, which laser is used for posterior capsular cataract, Prasun?
So ND-YAG laser is used for posterior capsular cataract.
Any other points? Okay. Now,
The
what are the clinical
point
features?
meant
Yeah. Okay. Now, what are the clinical?
the point.
Okay. You speak.
So the point.
All right. No worries. No worries. Now, let's take up the next question. What are the clinical features of complicated cataract? Except, Sharath.
Opacity along sutures was not comes under the clinical feature of complicated cataract.
So otherwise, what else do you find in that? Polychromatic luster?
Polychromatic cluster, axial spread of opacity, posterior subscapsular opacity.
Absolutely. Very good. Now, what are all the conditions that lead to development of cataract because of some other disease in the eye? Prasun, among all these causes. Yeah, I think we lost Prasun. Okay. Prasun can rejoin. Okay, add to stream. Yeah, Prasun. Out of all these are all the causes of the complicated cataract except. You're able to hear? Okay.
Yes,
Yeah.
sir. I'm able to hear you clearly. It's a
Yeah.
vitreous movement.
Okay. So, subluxation of lens, retinal detachment, anterior uveitis, they are the other clinical conditions which are there in the eye that lead to development of a cataract, which is called complicated cataract. So, secondary to any other primary ocular disease is called complicated cataract. So, two things that you should not forget when you go to the exam tomorrow: polychromatic luster and breadcrumb appearance. Please don't forget. Now, the question goes to Shravan. Rosette cataract is seen in?
Trauma, blunt trauma.
Absolutely. So, the immature cataract, the type which causes severe loss of vision. What is your answer, Prasun?
So posterior subcapsular cataract.
Okay.
And why it is so? Because I can't answer.
Okay. So basically, whenever cataract leads to the development of vision loss, is it the central part involved or is it the peripheral part involved of the lens? They're all the deciding factors on how much of impairment of the vision that they lead to. So that is the clue why it causes why the posterior subcapsular location causes more severe loss of vision. Okay. Uh, now let's go to the next question. All these PowerPoint slides, everything are all available in the onlinembbs.com video library and the PPTs, no worries. So this session is mainly, the purpose is to make you to express your answers. So this is a rosette cataract, this is a traumatic cataract typically, which lead to development of a star shape. Now, rainbow cataract is due to what? Sharath?
Secondary cataracts.
Excellent. So this is a normal lens, immature lens, mature lens, hypermature lens, and this is when that lens which is liquefied is floating called Morgagnian, and this is how an intraocular lens looks like. Now, systemic diseases associated with the cataract. All these are the systemic diseases, except we have Ashifa Kaushik.
Except,
Yeah.
so except is phenylketonuria. As
Okay.
mentioned earlier, we saw sunflower cataract in Wilson's, and in diabetes also different. Even for galactosemia and diabetes mellitus, another cataract names were given, except for phenylketonuria, which is a metabolic disease.
Absolutely. Absolutely right. So now, Jack in a box, scotoma, where do you see? Sharath.
Fake, yes, sir.
Very good. So typically, whenever there is no lens available, aphakia, the object will look to jump in and out of the field view as it moves out and into the ring scotoma because of the aphakia. So this kind of sudden appearance and disappearance is called jack-in-box phenomena.
Correct.
Whenever there is no lens available, and that led to development of a ring scotoma is what you need to remember. Okay. So what you need to do is, first of all, you should know what is jack-in-box. Jack-in-box means this guy will be suddenly popping out and going down. That's called jack-in-box. Okay. So typically for entrance exam, tomorrow when you become dermatologist, you don't need all this crap. This is a post-traumatic stress after you get that top rank. So working knowledge is required to clear the exams, doctor, very important. Now, what is the side effect of the oral steroid? Once more a question to Sharath.
Cataract, sir. Side effects of oral steroids or cataract.
Absolutely. Then, Prasun, least common cause of blindness?
So
Very good.
refractive errors.
Okay. Cataract, corneal obesities, glaucoma, they are relatively more common cause of the blindness. What is the most common type of cataract?
Nuclear cataracts.
Which one?
Nuclear cataract.
Very good, very good. And what is the most serious complication of cataract surgery, Prasun?
Vitreous loss, which is the fluid loss.
Absolutely. So vitreous loss is one of the most terrifying complication of cataract surgery. So now let's go to the next question. Uh, yeah. Tupuliform cataract. From where does it arise, Sharat?
Posterior capsules. Posterior capsules.
Absolutely. And now, Prasun, how is posture chamber examined in a mature cataract?
So posterior chamber is examined by OCT test, which is optical coherence tomography.
Yeah,
Is yeah.
it's a B scan ultrasound. Posture chamber is examined in a mature cataract with a B scan ultrasound. Is you can be able to see that a vitreous hemorrhage, how it looks like. So this is all the blood, vitreous blood, how it looks like. And this is how a retinal detachment can be appreciated if you happen to use the ultrasound. And this is once more a posterior vitreous detachment with the vitreous blood and the choroidal detachment. And this is an example. This is the sclera and choroidal detachment and uveal effusion. So, etc., etc. So, B-scan mode is highly useful and helpful. So, we also have Dhanalakshmi, Ashima, and many more who are all online. So, if you like to join this debate together and make it a more fruitful, interesting exercise to prepare for exam, please don't forget, I'm typing here 900868 our helpline number. Please say that, send me the link for of the SteamYard for me to join. Okay, so now chronic use of systemic steroids most commonly lead to which complication, Prasun?
Sir, it's cataract, and it was another repeat question.
Okay. So it leads to cataract. Now, partial capsular cataract is treated by this once more a repeat question, NDR. Now, let us take a few anatomy questions. The structure with highest refractive index, which one, Sharat?
Lens, sir, lens.
Very good. So, if you look at cornea, it is 1.376. Aqueous humor is 1.336. And vitreous is 1.337, but 1.386 is lens. And in the center, it has highest amount of index, 1.406. So these values, you have to be doubly sure when you go for the exam tomorrow. Now, maximum visual field is seen in Prasun. Which part of our visual field is maximum? You can, are you checking right away? Yeah. Okay, Sharath, you can
Yes, yes.
yeah, Sharath, you can give an answer. I think we lost Prasad.
Temporal.
Very good, very good. Okay, so temporal. So superior is 60 degrees, inferior is 75 degrees, temporal is 100 degrees, nasal is 60 degrees. That is what you need to remember. Prasun, you need to unmute your mic. Okay. Now, what is the axial length of the orbit, Sharath?
2.5 centimeters.
Absolutely. So what is the junction between the retina and the ciliary body? What do you like to call it as?
Ora serratus. Ora serrata.
Ora serrata. Absolutely. So these are all the glands of eyelids except.
So lacrimal glands, sir.
That's right.
The
Gland.
glands were included were glands of Jay's, meibomian gland, and glands of Mohs.
Excellent. So meibomian are modified sebaceous and located in the tarsal plate. Gland of Gis is also modified sebaceous associated with lash follicles. Gland of Mole is a modified sweat gland.
Okay.
So these are the points to be remembered. Now, I wonder, Prasun, is she having any uh, okay. Prasun may need to re-log in. Presently, I removed you. Once more, you add the stream. Okay. She may need to re-log in. Okay. Now, the ocular motor and cochlear nerve, how do they pass? Sandeep.
Through superior orbital fissures.
Very good. So you need to know that what are all the structures in superior orbital fissure. Once more, purely Bhatti Varnamala cheese hai. Superior ophthalmic vein, lacrimal nerve, ophthalmic arteries, recurrent meningeal branch, and frontal nerve, cochlear nerve, superior division of oculomotor, nasociliary, abducens, and inferior division of oculomotor and inferior ophthalmic vein. So you need to remember the superior orbital fissure, what is passing, optic canal, what is passing, and inferior orbital fissure, what is passing. You have to be 100% sure about. Good. I think Prasun is back in the game. Yeah. Good. Are you able to hear Prasun?
Yes, sir.
Okay. Now, which component of the eye is having maximum refractive index, Prasun?
The center of the lens.
Absolutely. The center of the lens has maximum, just before we discuss. What is the power of cornea? Sharad?
45 diopters.
Absolutely. 45 diopters. The total refractive power of the cornea is approximately 40 diopters. And 47 diopters for the anterior surface. And the posterior surface has more negative power. So that's what you need to remember. Now, Bowman's membrane, Sharad, what is true about it?
It prevents infection more than Descemet's numbers.
Correct. So it is the one which acts like a policeman, like our border security force, and prevent infection more than the Descemet's membrane. Bowman's membrane is more powerful. So you need to know what are all the layers of the cornea, what is their individual functions, everything. So I leave the literature for you to do the revision now. Question: what is the size of optic disc?
So 1.5 is the size of optic
Good.
disc,
1.5 mm.
and
Yeah.
this by cup ratio more than 1.5.
Okay. Yes.
I'm not
Now,
getting, but this by cup ratio is there.
okay. Now, which muscle is affected in increased intracranial pressure? Sharad.
L- Muscle, lateral rectus.
Huh?
Lateral rectus muscle.
Absolutely right. So lateral rectus is supplied by abducens. Abducens nerve is the one which is the longest subarachnoid course. Because of that, it is the most often affected nerve in whenever there is a rise in intracranial tension, and that is the reason the lateral rectus is most vulnerable. Is what you need to remember.
Yes.
Now, doctor, what is the volume of eyeball, Prasun?
It's a 30 ml, and it's a factual question.
Sorry?
Sir, 30 ml.
30 ml or 30 ml or 6.5 ml?
Sir, 30.
30 ml is almost a small peg of whiskey. I don't think volume of eyeball can be that big, right? Sharad, do you want to also stick to 30 ml or 6.5?
Volume of eyeball 30.
Sorry, sir, it's 6.5.
Uh, okay, we'll come back to that. Now, Schwab-based line, where do you see, Sharad?
Seen in Desmond membrane, sir. Posterior limit of cornea, Desmond's membrane.
Very good. So it is that anatomical line which is being found on the inferior surface of the eye's cornea, and it is the one which is defining the outer limit of the corneal endothelium layer. That's what you need to remember. Okay, so this is how Schwab-based line acts like a important landmark whenever you are doing gonioscopy and knowing whether it is a narrow or a broader canal. Now, what are the various structures in the angle? I can see till Schwab-based line is the mnemonic. I is iris root, then ciliary body, then scleral spur, trabecular mesh, and Schwab-based line. That's what you need to basically remember. I'm so happy to see 22 online students in this group discussion. Once more, Doctor, I like to tell all of you, please do ping to 9000868 and tell that I want to join these combined study sessions on StreamYard with Dr. Murli Bharadwaj and other classmates across the country. So today we have Prasoon all the way from Nasik, and our Sharad Bhai is from Visakhapatnam, right? So last time we had from Patna, Dr. Padmaja, right? So that's how, if you are preparing for a session that brings interest for you to study, the whole purpose of a teacher is, how can I make you all study, right? It's more than teaching. You know better than me many times. But my job is to stimulate you to read, to present, to prepare, to remember, to retain and recall in the tomorrow's exam. Now, doctor, which vitamin is present in aqueous humor? Sharad?
Vitamin C, sir.
Absolutely. So,
Nutrition.
Prasoon, with regard to the rods and cones, what is accept?
So Purkinje shift
Okay.
is all color seen as gray in bright light, which
Okay.
which is false statement.
Right. Cones for the photopic vision. Form sense is identified in the fovea centralis. Rhodopsin is the visual pigment. They're all true statements. Now, Purkinje shift. A red rose in daylight makes red petals appear brighter and the green leaves appear duller. And in the twilight, that means in the evening, when it is sunset, when you are getting the darkness, the red petals appear duller and the green leaves appear brighter, which is called as Purkinje effect. Even when we are preparing for entrance exam, the May is like a daylight. It will make you feel that there is a large amount of time available for me. I can take my own sweet time to make a start. No. The red rose in daylight makes the red petals appear brighter. The May makes you to feel that you have a lot of time available in your preparation. No. And when the notification comes, it is like twilight. Suddenly the red petals appear duller. You feel that the time is not there at all. So, doctor, it is all a sense of relative perception. So, if you are studying every day, Every Sunday, if you are taking a grand test and participating in discussion, knowing your scores, you are bound to become the winner. Okay? Now, doctor, the next question. Duas layer, where is it present? Sharon.
Between deep stroma and descendant membrane, sir.
Excellent. So, between deep stroma and descendant membrane. So, if you look
Mnemonic
at,
is triple D.
yeah, if you take the cornea, you have epithelium. Then this is the Bowman's layer. Then this is the stroma. Then here you are having what is called Duas layer, right? So Duas layer is between the stroma and the descendants membrane, and below that you are having endothelium. That's what you should remember. Okay. Now, what is the size of optic disc once more, Sharat?
1.5 mm.
Excellent. So optic nerve, it starts from the optic disc up to optic chiasma, you still call it as optic nerve.
Optic nerve.
And yes. Now let us go to the next question. Strabismus is a favorite topic. These are all the ocular muscles supplied by cranial nerve 3, except pressure. Are you there?
Yes, sir, I'm there.
Yeah.
Superior oblique isn't supplied by
Except
cranial nerve 3.
which one? Which is not supplied?
Superior oblique.
Yeah, superior oblique. Except
It
superior
is
oblique.
supplied by cranial nerve 4, sir. SO4.
Right, trochlea. Now, about oculomotor, what is except? Sharat.
Nucleus
Sure.
is located in the lower midbrain. It's a false.
Right. So, its nucleus is located in the upper midbrain,
Upper
and because oculomotor supplies a muscle called levator palpebrae superioris, which elevates your right? It elevates your eyelid. So any injury to that lead to development of ptosis. Now, person is not able to look down. Which extraocular muscle is affected, Prasun? Should.
Sure, superior oblique.
Absolutely. It is the superior oblique. So, the superior oblique is innervated by the trochlea, as all of you know. And any dysfunction of that, there is a loss of downward inner movement of the eye, and that lead to a disconjugate gaze. That means whenever you are looking towards one side, suppose you are looking towards your right will undergo abduction, your left eye will undergo adduction. That's called a conjugate movement. So that get affected the moment the trochlear nerve is affected. So once more, doctor, this is a very important statement you need to remember. What are the primary and secondary actions? One question, short, Sharat. Take it as my word. You will remember me in exam hall. FMG, December. When is the FMG exam expected, Sharat, this time?
August.
When? August, right?
August.
In August, one question definitely comes on the primary secondary actions of these extraocular muscles, and you will remember me in the exam hall.
Sure.
So you can remember superior oblique functions by the mnemonic called solid. S is superior oblique, L is lateral rotation, I is intorsion, D is depression. Will you promise that you'll remember? Come on, Sharat, once more along with me.
Superior oblique, lateral rotation, intorsion, depression.
So you'll remember
superior oblique muscle action.
Yeah. So, and inferior oblique is the only muscle which is arising from the floor of the orbit. All other extraocular muscles arise from the orbital apex. This is a point you need to remember. And extraocular muscle is attached to the area behind the macula, is inferior oblique. Now, another thing mnemonic to remember: all superiors are intorters, whether you take superior rectus or superior oblique. All inferiors are extorters. You know, extortion means कब्जा करना, किसी के घर को कब्जा करना extortion बोलते हैं. That is a very inferior nature. All inferiors are extorsers. Inferior rectus and inferior oblique. All recti, both superior rectus, inferior rectus, all recti are adductors.
Adductors.
All obliques are abductors.
Abductors.
So, whenever I say superior, all superiors are what? All superiors are intorted. So, superior oblique is a intorted, intorsion of the eye, and all obliques are abductors. So, it also leads to abduction. If I ask you what is inferior oblique doing, all inferiors are extorters. So, it will lead to extortion. And it being an oblique, it also leads to development of abduction. So, that is how you should be able to remember for the tomorrow's exam. Now, secondary action of superior rectus. Come on, Prasul.
So all recti are adductors. So the answer is A, adduction and intorsion.
Very good. Adduction and intorsion. Excellent. You'll remember it forever, right? Now, a person is not able to look down. Which extraocular muscle is affected, Sharad?
Inferior rectus.
Absolutely right. In lateral rectus palsy on the right side, the face of the patient is turned to which side? Prasun.
So towards the right.
Towards the right. Absolutely. So, because the weak extraocular muscle cannot move the eye fully, the patient will compensate by tilting or turning the head in the direction of the action of the weak muscle. So, if you know the direction of action of the weak muscle, what is the weak muscle here? Lateral rectus. Lateral rectus, what does it do? It leads to abduction. So, abduction of the right eye means the person is supposed to look towards the right side. If he is unable to look towards the right side because of the abduction to right is weak, he will try to turn towards the right side. So that's very important. Now, if there is a right superior oblique palsy, this is a beautiful question. This is a beautiful question. The head tilts forwards and to the left. The head turns or tilts to the direction of the action of the weak muscle. Please don't forget. So this is a favorite MCQ. Once more, let me tell you, Sharath, paper out, FMG August. One question definitely they will ask you. A person is tilting his head forwards and to the left. Which muscle is affected? Right superior oblique palsy. That is what you are going to answer in the tomorrow's exam. Barabar? Now, synergistic muscle to the right inferior oblique, which one? Prasun. Which muscle is called synergistic muscle? Barabar? Even at 10:30 p.m. we have 20 online students. Before exam, this will be
right superior recti.
Very good. So, right superior rectus is considered to be the synergistic muscle of right inferior oblique, is what you need to remember. Maddox rod, where do we use, Sharath?
Strabismus.
Absolutely. So, this is the Maddox rod. How do we use it? How will you test the squint? Everything earlier we discussed previously. I leave the literature for you in the onlinemmbbs.com video library along with the PowerPoint. Please take a little opportunity to go through the video, right?
Yes.
Now,
Yes. It's a macular function test also.
right. It's a macular function test, one among the macular function tests. Macula is the central part where the visual acuity is highest. Now, Hirschberg test. Have you heard of it, Prasul? What is your answer?
Sir, using litmus paper,
Okay.
they
What's the purpose of it?
for
For
squint,
squid.
strabismus.
Yeah, strabismus. When the patient is fixating a light at 33 centimeters, you will throw the light and you will see the corneal light reflex from the center of the cornea, how much it is deviated. So that is how you will identify. If there is a strabismus, then it won't fall centrally, but it will get deviated. You got confused with Schremer's test. What you said is litmus paper and then looking at the tears is Schremer's test, not Hirschberg.
Dry eye test.
Correct. That is the one which is seen to look for any drying of the ocular secretions in
Okay.
conditions like the Sjogren syndrome, etc., etc.
Diabetic.
So now, doctor, what is true about paralytic squint? Sharath,
Head tilt towards the rectus muscle paralysis.
towards or opposite?
Towards.
Absolutely. Now, unilateral oculomotor nerve palsy, what does it lead to? Prasun?
Sir, loss of accommodation,
So, what does it lead to? Loss of
loss of
accommodation.
accommodation.
Absolutely. Isolated third nerve palsy with a pupillary sparing. Sparing is very important word there. Where do you see Sharath?
Diabetics.
Right. All medical conditions, diabetes, hypertension, atherosclerosis, they all lead to pupil sparing oculomotor palsy. All surgical conditions lead to pupil involving oculomotor palsy. Pupil, what happens to pupil if the oculomotor palsy is there, Prasun? Do you get meiosis or mydriasis? When
Meiosis.
huh?
Constriction. Yeah.
Meiosis
Meiosis.
or mydriasis if oculomotor palsy is there. Yes,
Sir,
doctor.
meiosis.
No. How can you do such a mistake? Huh? Come on, doctor. I'll explain you.
Okay.
Typically, oculomotor nerve carries parasympathetic fibers. This is retina, doctor, right? From the retina starts the oculomotor nerve. It reaches optic chiasma. Then from optic chiasma, it is while traveling. Typically, it gives rise to the fibers which reach what is called pretectal nucleus. Pretectal nucleus on both the sides. Pretectal nucleus, you have it in the midbrain. From the pretectal nucleus, the fibers will go to both sides Edinger-Westphal nucleus. Edinger-Westphal is a parasympathetic nucleus. From Edinger-Westphal, I'm sorry, I'll take a white pen. From the Edinger-Westphal, the fibers will go to ciliary ganglion. From ciliary ganglion, the fibers will go to the sphincter pupillae in the eye. Sphincter pupillae in the eye. And that is the reason whenever the light falls, the fibers will report to pretectal, from pretectal both sides Edinger-Westphal, from Edinger-Westphal to ciliary ganglion to sphincter pupillae, and that lead to constriction of the pupil, meiosis, when the light falls. Agree? But if at all there is any paralysis of oculomotor, then these parasympathetic fibers are paralyzed. So what will happen because of that? The sphincter pupillae become paralyzed. And there is the unopposed action by the dilator pupillae. Dilator pupillae is supplied by sympathetic fibers. So there is an unopposed action of the dilator pupillae, and that leads to development of pupillary dilatation. So that is the reason mydriasis is a feature that you see whenever oculomotor palsy lead to parasympathetic palsy. बराबर? समझ में आ गया? Could you follow?
Yes, sir.
Yes or no, doctor?
Yes, yes, sir.
Yes, sir.
If it is yes, now Sharat is going to tell me the track. Are you ready? From retina, where we will go? Sharat?
Yes, sir.
From retina, optic nerve.
Optic nerve.
Optic nerve reaches optic chiasma.
Optic chiasma.
From optic chiasma, you get the optic tract.
Yes, sir.
From optic tract, the fibers will go to which nucleus?
Vesting for nucleus.
Pretectal nucleus.
Pretectal nucleus.
From pretectal, they go to bilateral. Bilateral. Come on. Edinger-Westphal.
Edinger-Westphal nucleus.
Edinburgh-Westphal nucleus, sir. Bilateral
From
Edinburgh.
Edinger-Westphal, they will go to.
Ciliary ganglion.
From ciliary ganglion, they will go to.
Sphincter pupillae.
Sphincter pupillae.
Super, super. See, doctor, any amount of online coaching, unless we have this kind of one-to-one interaction, then only we will be knowing student understood or not, right? So that is the whole purpose of this combined study together. I want more and more number of people to join the STEAM yard discussion with me, so that we will have more fun preparing together. At the same time, we will also do a live broadcast. Okay, so those who wanted to join the STEAM yard live discussion with Dr. Murali Bharadwaj and all our other classmates, please drop a line. 9000-868-356 is our helpline, and say that we wanted to join, and you will be sent the StreamYard link for you to come into the broadcast, so that हम सब मिलेंगे, हम सब पढ़ेंगे, हम कामयाब होके दिखाएंगे दुनिया को कि हम we are able to achieve the top rank, right? So that is the goal. We will finish up to another 3-4 questions before we call it a day, doctor. Do you think, Prasun, this is much better than Zoom and all that? What do you say?
Yes, sir. I'm improved.
Yeah.
I'm improving.
Zoom is better or this is better?
Sir, this is better.
Yeah. And when you log in into this session, doctor, don't forget to have a good internet connection. And only you log in through the Google Chrome. So that is the plan. Okay. Now, quickly, once more, Hirschberg test for strabismus.
Strabismus.
Now, the action of superior rectus, Prasun.
So elevation and intorsion.
Absolutely. Elevation and intorsion. Angle kappa is between which axis, Sharat?
Visual axis and anatomical axis.
Absolutely right. So strabismus is a misalignment of visual axis. So what is visual axis? The line of the vision extending from the point of fixation to the fovea is called visual axis. And anatomical axis, it is a line passing from the posterior pole So the center of the cornea is
Cornea.
called anatomical axis is what you need to remember. So the angle between the visual axis and the anatomical axis is called the angle of kappa. And just before we discuss, if you look at the fovea, the point where you have the highest amount of visual acuity, it is just temporal to the anatomical axis. It is just temporal to the anatomical axis. And that is the reason it will cause the reflex just nasal to the center of the cornea. So that is the reason in a normal eye, the angle of kappa, which is the angle between the visual axis and the anatomical axis, is around 5 degrees. Positive angle is what you need to remember. Whereas if somebody has got a high myopia, always remember, bigger the eye, greater the myopia. Smaller the eye, greater the hypermetropia. That is the rule. So whenever there is a high myopia, the fovea lies nasal to the optical axis. So the corneal reflex lies temporal to the center of the cornea. That is what you need to remember. So that is the reason in myopic individuals you have a negative kappa angle. Hypermetropics you have a large positive kappa angle, and normal kappa angle is positive, which is 5 degrees. ये 3 चीजें याद रखो भाई, बाद में एमएस ऑप्थेल्मोलॉजी में सीट आ गया तो बात की बात रात की बात. Now, let's go to the next question quickly. Maddox rod. Where do we use once more, Sharad?
Latent squint and distant vision.
Absolutely. Lateral squint, distant vision. In distant vision. That's how it is being done. In uveitis, what is the site of keratic precipitate prism?
So corneal endothelium.
Very good. Corneal endothelium. Corneal endothelium. Very good. We started streaming 60 minutes ago, and we are able to finish 63 questions. One question, 1 minute. If we all sit together in 10,000 minutes, 10,000 questions khatam ho jayega. Are you all ready for that? So,
Yes.
So what is the site of keratic precipitate? Corneal endothelium. So what are keratic precipitates? Proteinaceous cellular deposits which occur at the back of the cornea on the corneal endothelium. They are arranged in a triangular fashion, occupying the center and inferior part of cornea. Center and inferior part of the cornea. That's called the Orlet's triangle. Why they get specifically deposited in that location? Because the aqueous humor will have convection currents and that land it in the Orlet's triangle is what you need to remember. Once more, the type of keratic precipitates in granular matters versus non-granular matters.
Non-granular matter.
Mutton fat, large, greasy, macrophages, epithelioid cells, that is granular matters. Koyapis iris nodules at the pupillary border. Busacca nodules on the iris. So this is granular matters. But you don't have any iris nodules with the non-granular matters uveitis. Quickly tell me, Sharad, what is uveal tract? What are all the components of uveal tract? I, C, C, U. U is uveal tract. I is iris. C is ciliary body.
Ciliary bodies.
And C is choroid.
Correct.
Once more, tell me, Sharad, I is
Iris.
C.
Ciliary bodies. Choroid.
That forms uveal tract.
Uveal tract. Yes.
So lymphocytes, plasma cells are what you see in non-granular matters type of
Granular matters.
uveitis. That's what you need to remember.
Yes.
So you find this kind of partial synechia, which are the classical clinical feature. There's a development of ciliary injection, etc., etc. I leave all this literature in the onlineMBBS.com video library, so no worries. Now, what is the immediate management of acute uveitis, Prasun?
So cycloplegics, like
Very good.
psychopental.
Excellent. So, cycloplegics, the ones which paralyze the sphincteric spasm, that's what you need to basically administer in case of uveitis. Now, uveitis main objective is what? Vision threatening complications you have to prevent. And you need to relieve the patient's discomfort, pain, and treat the underlying cause of uveitis. So we give tropicamide, cyclopentolate, phenylephrine, which are short-acting, and long-acting like atropine. These are the non-specific treatments that we give. And we give steroid, corticosteroid, in order to bring down the inflammation. Uveitis is all inflammation. We also give NSAIDs, especially in uveitis because of the rheumatoid arthritis people, if they happen to develop the uveitis. Now, uveitis complications also, inflammatory glaucoma can occur, complicated cataract can occur. Uveitis is involving iris, ciliary body, choroid. Choroid is an extension goes to retina. So, retinal detachment can occur because of the uveitis. And there can be a phthisis bulbi, which can occur, which can be especially very painful. And you may need to do enucleation for the purpose of phthisis bulbi. What's more, what are all the indications of enucleation? Evisceration. You need to basically prepare and do the revision doctor. So with that, we will conclude the successful joint venture we have started today to study together. And I hope you all enjoyed this session. Next time, bring your friends also. Ask them to join. Tell them that they will give a cup of electronic tea, right? To Chai Pe Charcha with Dr. Murli Bharadwaj. And I always appreciate Prasun, always courageous, ready to come and join online in a discussion. That should be the spirit of preparation. So thank you, Sharath, also, and good luck for your preparation. And we'll once more meet more periodically with this kind of online discussion. And also, thanks for the online students for joining. Good night.
Good night. Thank you.
Good night, sir.